Assalamu alaikum, respected chairperson, moderator, panelist, and all participants. I am Dr. Esmat Ara, now going to present my topic is role of echocardiography in infective endocarditis. It's a disease of microbial infection involving the endocardial lining of intracardiac structures such as heart valve, mural endocardium, chordal structures, deeper layer of myocardium, pericardium, intracardiac devices, and prosthetic heart valve. This infection is invariably fatal if left untreated. Echocardiography of both modalities play a vital, a pivotal role in the early diagnosis and management of infective endocarditis. Transthoracic echo should be done in all patients at first because it is non-invasive and specific. It can detect the presence, anatomic location, size, and number of vegetation, intracardiac complications, valvular regurgitation, and overall cardiac function. But it is not adequate for prosthetic valve endocarditis or device-related endocarditis. Less than 2 millimeter vegetation cannot be detected by this modality, and in 20% cases, this modality is technically difficult due to poor echo window. On the other hand, transesophageal echo has high specificity and sensitivity. In patients with negative transthoracic echo but clinical suspicion is high, transesophageal echo must be done because it can detect vegetation greater than 90% cases of infective endocarditis because of its high resolution. It is essential for prosthetic valve-related endocarditis and intracardiac device-related endocarditis. It can also detect complications like myocardial abscess, valve perforation, and intracardiac fistula. But this is not widely available. This is invasive, and this is a little bit, to some extent, uncomfortable to the patient. Recently, we have come across 3 patients of infective endocarditis from 3 different subsets. Our first case was a 40-year-old gentleman. He had been suffering from fever for more than 2 months. He was not known to have any cardiac conditions. He went to many different hospitals and underwent lots of investigations, but that failed to show the cause of fever. Then he came to us. We did an echo, which shows flail PML and a vegetation attached to its atrial size, causing mitral regurgitation. This patient was died due to septicemia and multi-organ failure. Our second case was a 52-year-old gentleman, underwent ASD device implantation 1 year back. He developed fever for more than 3 months. His initial transthoracic echo was negative, then transesophageal echo was done, and a vegetation was detected on the aortic side of the device. Our third case was a 54-year-old gentleman. Valve replacement was done few years back. He developed fever for more than 2 months. Then he came to us. We performed a transthoracic echo, which revealed a vegetation over the aortic valve. But this patient also had ended up with a fatal outcome, and he also died. Technical advances in echocardiography, particularly development of transesophageal echo, have revolutionized the diagnosis and management of infective endocarditis. Despite having limited sensitivity and specificity, transthoracic echo is the essential part of initial diagnosis and management of patients with suspected infective endocarditis. Negative transesophageal echo does not rule out the possibility of infective endocarditis, so it should be repeated within 7 to 10 days. Both modalities of infective endocarditis provides complementary information regarding management and follow-up and prognosis of patient with infective endocarditis, and it should be used in conjunction with clinical data. Thank you.